Hi, everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we are going to be discussing women's cardiovascular health with a clinical cardiologist who specializes in women's cardiovascular disease, Dr. Nadia Abelhad.
Hi.
Thank you for coming on.
Thank you for having me. Excited to be here.
Yes, this is a podcast that I have been searching for the perfect guest to have on to discuss this because I just find it's more fun when we have a guest and not just hearing Dr. Brian and myself talking.
Exactly.
So we are very passionate about heart disease, let alone particularly women's heart disease in our office. And I love educating my patients about the difference between heart disease in men and women. So I cannot wait to dive into this topic, but I'd first love for you to introduce yourself a little bit to our audience. Tell them a little bit about your background and how you decided to go into cardiology, let alone specializing in women's health.
Hi. So once again, my name is Nadia Abelhad. I am a clinical cardiologist. I decided to go into women's cardiovascular disease specifically because it is an underserved area. I noticed myself that when certain women, specifically of the conception age, were pregnant and had issues with their pregnancies, such as a preeclampsia or chronic hypertension, a cardiologist was too afraid to see them. It's almost like pregnancy was a plague. And because of that need, that niche, that is really what drew me to go into women's general cardiovascular disease.
Oh, that's great.
And it seems to be so underrepresented, right? Deanna and I were lucky enough to have seen Dr. Nanette Wenger, who's probably one of the giants of female cardiovascular medicine. And we've learned so much from her, but we still have so many questions. And heart disease is still the number one leading cause of death in women.
Absolutely.
I mean, more than cancer.
Yes,
and people don't realize that.
Yes. So there's all this media attention about breast cancer, which is fantastic. If someone wears a pink ribbon, it is easily distinguishable. But if someone is wearing a red ribbon, perhaps, which stands for cardiovascular disease, specifically in women, people may not quite know what that means. So It's a media topic that is underrepresented, under-talked about, and it is certainly something that should be widely spread throughout.
Yeah, I was thinking the other day, I was watching TV, and when you watch TV, you only see men have heart attacks on TV, right? You never see a woman having a heart attack.
Nope. You're right. Like in movies and TV programs, you're right.
And think about how you see it depicted or displayed on TV. It's a man using his hand going, oh, crushing chest pain. There's something sitting on my chest. But guess what? A woman who may have a heart attack doesn't look like that.
Exactly. Can we actually go ahead and just dive into like some of the symptoms that differentiate between heart attack per se, or we could say even the symptoms of developing heart disease, shall we?
I love that you asked that. So let's talk specifically about heart attack and how it may look like in a woman. So what we know is that women have some type of chest abnormal sensation plus an additional symptom or sensation. So that chest sensation can happen anywhere in the chest. It can be upper, lower, just right. It's defined as the diaphragm and above. It can happen on the right shoulder. It can happen on the left shoulder. That plus an additional sensation. That sensation may be dizziness, fatigue, lightheadedness, tingling, sweating. So because the symptoms are so vague and nonspecific, what I've probably just described, you have probably felt, I know I have felt, right, is why that it's under-recognized and women themselves may not know that they're having a heart attack. So the number one takeaway really should be, if you notice an abnormal sensation you've not previously had in your chest area, listen to your body, seek medical attention.
Yeah, I think often women are like, oh, this is probably hormonal or stress, right? Like, I mean, they're running the family most of the time, and it's easily chalked up to something else and overlooked or ignored, right? And these symptoms could, like I said, it's not that when you're having this symptom, you're having a heart attack. It could be the symptoms of developing heart disease. Correct?
Correct. So developing heart disease typically can show other things. For example, headaches, generalized fatigued, right? So once again, my takeaway is your body sends you signals. Listen to those signals. If you feel like overall something is not wrong, you may not be able to put your finger on it, but seek medical attention.
Yeah.
So we talked about hormones. How do hormonal changes, hormonal shifts affect cardiovascular disease like puberty, pregnancy, perimenopause, and the menopause?
That's a great question. I want to specifically talk about the perimenopausal stage. That's a hot topic. So, as we know, the perimenopausal change, there's a change in your estrogen and progesterone levels. Specifically, your estrogen levels are decreasing. And with that change, there's a number of change in the hormonal profile of your body. So, for example, we know with decreased estrogen levels, your lipoprotein A increases about 25%. Your LDL increases about 20%. Even the changes in your small blood vessels, your intimal thickness increases, plaque or calcium increases. So all these protective effects that women previously had with estrogen, we start seeing those changes. Average age, median age in the U.S. is around 51 for menopause, but perimenopause can start much earlier, 35, 40.
Do you find that early hormonal replacement affects that or mitigates some of that?
That's a great question. To date, we do not have any data that shows that hormonal replacement therapy is a preventative treatment for a cardiovascular outcome, meaning a heart attack or stroke. It is counterintuitive, however, if I'm saying estrogen, you lose the protective effects. So wouldn't you gain it by that, right?
Exactly.
Right.
But what we understand is that even though it's intuitive and what makes sense doesn't always translate to basic translational science.
Are there any current studies though ongoing about that, or how old are those studies? That's you know what I mean. I just feel like since the Women's Health Initiative came out, I mean, when was
Which
that?
was with synthetic hormones, by the way,
Right.
not even with hormones.
Like I feel like nobody's really done hormonal studies since then, and that was what 2000 ish, yeah,
Early 2000.
Yeah.
So a little bit more about the data that we have. Let's expand upon that. So the Women's Health Initiative did look at synthetic hormonal replacement therapy, estrogen and progesterone, but you have to look at the patient population. What did those women look like? The average age of those women were right around early 60s. As we know, menopause average age is 51. And so with those women who took those, we saw that there was an increased risk of cardiovascular outcomes, specifically negative ones such as major blood clots. And what we've taken away from that is that that health initiative was not done at the correct age. There's the timing hypothesis, right? So we know that if you already have diseased arteries, hormone replacement therapy can sometimes make things worse overall. What do we mean by that? Meaning if you are the age of 60, you already have calcium, you already have high blood pressure, you may already have coronary artery disease, right? Hormone replacement therapy should have been started prior to those arteries being diseased, because some of those diseased arteries can be more sensitive to the negative effects, like a major blood clot, for example, right? So we need more data, we need more information in patients or women specifically who are starting hormonal replacement therapy, women who are in their mid-50s. That would be helpful.
I love hearing you talk about this. And since we do a lot of hormone replacement therapy in our office, there's times where if they are scared of the risk of heart disease and they have been more than 10, 15 years postmenopausal, we can also treat with just testosterone. We don't have to do the estradiol. That can help with lifestyle modifications, But we discuss that with our patients. And most of the time, by that age, a lot of our patients already have cardiac calcium score. So I would love for you to kind of mention also on that, what is the workup you would recommend for a female to see if they have that heart disease prior to or not?
And how does it differ from the workup for a man?
Great questions. So first things first is, in general, silent suffering should not be accepted, period. So if you have vasomotor symptoms, which can look like fatigue, which can look like memory fog, right? It is important that you speak up. I feel like, number one, most women don't even know to speak up, right? So if we're treating that, absolutely, let's go down the workup pathway. If you don't have those vasomotor symptoms, right, and you're doing it for a prevention standpoint, then hormone replacement therapy is not appropriate in that aspect for now, given the data we have. So let's say we're going down the former pathway. You feel horrible. Your quality of life is not appropriate or acceptable for you. We need to look at an overall cardiovascular risk assessment. The earlier, the better. Like we said, we want to do it before 10 years of menopause. So ideally, right when you're having those symptoms. In terms of overall risk reassessment, that looks like a couple things. Family history is important. And we all know about the traditional risk factors from your history, right? High blood pressure, high cholesterol, tobacco use. But let's talk about the non-traditional women-specific risk factors. Do you have chronic inflammation? That's the general question. That can look like rheumatoid arthritis, lupus, but also, do you have any history of preeclampsia, preterm delivery, gestational hypertension, gestational diabetes, right? All of those things cause chronic inflammation, and we want to take that into account in the history. That's something specific to women that is overlooked. The other thing we want to look at is blood work. There's certain things we can look at the blood work, for example, apolipoprotein levels, high sensitivity CRP. These are all kind of general audience. We're looking for markers of inflammation.
Absolutely.
Then we also add a component of imaging. Imaging can have a lot of formats. Everyone, I think, is very familiar with the calcium score, right, to see how much calcium or plaque you have in your arteries, but also ultrasounds. Is there evidence of plaque or calcium elsewhere outside? Because plaque does not discriminate. If it's in one area, the chances of it in being the other beds or vasculature is a high likelihood.
So you're thinking maybe like a carotid ultrasound,
carotid
or
ultrasound,
aortic ultrasound,
or a lower extremity arterial ultrasound.
Okay.
Basically, an ultrasound of any artery that you may have in your body.
Mammograms can pick
Can
up.
mammograms
calcified.
often, right? If you're going to the dentist and you're getting x-rays, we pick up calcium in the carotids or blood vessels of the neck, right? So we do all of those. Now, we also can add in a component of a risk score, right? The common risk score that we tend to use is an ASCVD 10-year risk score. I have a problem with it because it doesn't incorporate women-specific factors, so it typically undermines someone's risk, right? So after we do a systematic approach of adding all the blood markers, history, and imaging, then we can give a personalized risk assessment and then have an educated conversation with the patient and say, what is a risk you are willing to accept? Is it 5%? Is it less than 5% of overall events, and would this be acceptable in light of your quality of life? If that answer is no, then there's a clear answer in how to move forward. Perhaps hormone replacement therapy, the benefits outweighs the risk.
Women also tend to get microvascular disease, which, is there any good testing or any screening for that?
I'm so happy you brought that up. So something to be aware of is when we think about plaque and blockages of the blood vessels, right, we're thinking about the epicardial coronaries. So those are the big blood vessels we can see. In fact, that only makes up 20% of the overall blood flow that's given to the heart. The microcirculation, or the tiny blood vessels in the heart that we can't see, actually makes up 80% of that. And so our traditional modalities that we have, something like a catheterization, a CAT scan with contrast, cannot see those tiny blood vessels. So currently we have something called cardiac PET, which I'm very passionate about. Cardiac PET is a way to actually, in gold standard, diagnose someone who may have diseases of their smallest blood vessels. That is a simple test that takes a couple of minutes, and it does not involve any contrast or dye. And with that kind of test, we're also able to actually measure the blood flow throughout those blood vessels to identify someone who may have something like diseases of their small blood vessels. Another note to point out is that sometimes people don't have issues with the blood vessels itself, but they have issues with the hormonal biofeedback and circulation, meaning they have endothelial dysfunction, meaning when their blood vessels need to increase in size to accommodate a higher heart rate, or if you're exercising, the blood vessels, for whatever reason, doesn't listen to the feedback from nitric oxide, for example, and increase in size. So that's another way we can detect a type of endothelial dysfunction through cardiac PET.
Wow, that's awesome. Is that covered by insurance or?
Yes.
Wow.
Great question. So, anytime someone gets a stress test, cardiac PET, if they're not able to exercise, is an indication to get that. So, it's the same kind of coverage with Medicare specifically. With commercial payers, it is different. Certain commercial payers may want prior authorization. But if your doctor is looking for coronary artery disease or blockages of the blood vessels, that is an absolute appropriate indication to get something like a cardiac PET.
Excellent.
Wow. So if somebody had, say, you have an older adult, like say 70s, right? And they were having that persistent fatigue, couldn't figure out why. So then they end up seeing cardiologists. They end up getting a stent. It was indicated at that time, apparently. They felt better right after for a short time period. That's it. Now they're fatigued again. And it's almost like a relentless fatigue. We've already ruled out like depression. We've already ruled out, and we've tried hormones, didn't feel any better. Like certain things, right? Where iron made them feel better for a little while because they were also iron deficient, but now they're fatigued again, right? So it's just like, what is causing this? Would that be a candidate for maybe this cardiac PET?
Absolutely. So an angina equivalent is generalized fatigue. The first question I would ask to that workup is, does that fatigue improve with traditional anti-anginal medications? Because that may be able to help you along, pointing you through that pathway if you are suspicious of that. But even if the answer is no, and you have a high index of suspicion, then yes, cardiac PET would be able to absolutely answer the question, is that fatigue due to perhaps an issue with the microcirculation?
Very interesting. And I love how you said the anti-anginal. So those are also, don't those tend to be vasodilators? Can you explain a little bit about that and how an angina to people out there is chest pain, which almost everybody knows that by now, but.
Yeah. So let me clarify on anginal equivalent. So there are people who have symptoms such as profound fatigue, typically with exertion, shortness of breath with exertion, right? So that sometimes goes kind of under-recognized. So that's what I mean by anginal equivalent. In terms of the medications, so there's two major classes. One are the dilators, basically increase the blood vessel size. Those typically are nitrates, Imdur, isosorbide. And then you have another class, the beta blockers. Those are medications that people may have heard of that they use for performance anxiety. But what they do is lower the work the heart has to do. So lowers the heart rate, lowers the blood pressure.
Perfect. And we've been talking about the microvascular diseases. And, when we go to the conferences, we hear the terms INOCA and MINOCA. Can you explain that a little bit? Obviously, this, for our audience out there, because we have other people who probably have never even heard of those terms.
Yes, I'm so happy you brought that up. So MINOCA stands for myocardial infarction without obstructive coronary artery disease. That is a mouthful, but the takeaway is that you have damage to the heart due to the tiny blood vessels. It's been a very hot topic because it is something that was underdiagnosed because our traditional modalities that we talked about, CAT scan, catheterization, could not detect it. Cardiac PET and MRI can detect it. It is something that is more frequently seen in women, and that's why it's been a hot topic.
Now, when somebody, say a woman has the chest sensation and one other, like they've got jaw pain, and they go to the ER and they run, do they do in the ER? I don't think they do.
Components.
Right.
Yeah.
That's where I was heading. But they don't do imaging right away. They'll do like EKG, and EKGs can actually be normal, right, with this symptom, with this type of heart attack. So then the troponins, though, is what the answer will be, right?
Right. So the troponins can be elevated, and sometimes they may do a transthoracic echocardiogram or an ultrasound, and they may see that a portion of the heart is weak in a territory. So there are a lot of other testing they may do, but the takeaway is that testing can be normal.
Yes.
And women are also more likely to get uncommon conditions like spontaneous coronary artery dissections, right? Is there a reason why women are more likely to get that than men?
Well, it's more stressful to be a woman. Yeah, so it's overall unclear. We suspect or we think that it's due to a big change in the hormonal levels and the autonomic nervous system output and a sympathetic surge. So that typically is seen in the fourth trimester as after a woman delivers. Specifically in the first 2 weeks postpartum, there's a huge surge and change in their hormone levels and nervous system input. And so that's why the spontaneous dissections that we see is highest risk in that postpartum period.
Very interesting. And does it have anything to do specifically with like the blood pressure
Yeah, so
or arterial pressures?
Yeah, so it's overall, like I said, unclear in terms of the exact mechanism. We have a lot of hypotheses, but it's thought to be more so the hormonal changes and the change in the autonomic input.
And speaking of stress, it seems that women are more likely to also get the stress-induced cardiomyopathy, Takotsubo.
Broken heart syndrome.
Yep. And can you maybe touch on that a little bit?
Absolutely. So it's not an old wives' tale. So what happened was that there were a series of women who had a profound weakness of their heart, specifically in the bottom portions of the heart. Their top portions of the heart worked just fine and actually overcompensated. And so whenever we looked at this in imaging, something like a catheterization, we noticed that their bottom portions, due to the weakness of the heart, started ballooning out. And the name of that balloon used to look like an octopus trap. So that's where the name Takotsubo derives from. In terms of what causes it, still same thing, unclear. We once again believe that it's due to profound stress surges due to an event, maybe a divorce, maybe a death, maybe it's just profound stress from your day-to-day life, from your work responsibilities. But whatever that provoking event and that increase in that sympathetic surge, for whatever reason, stuns the heart, and that heart becomes weak. We know that overall the prognosis is better and more favorable than other typical causes of heart failure. And we are able to treat those causes of heart failure with typical medications like we do for the rest of the population.
Wow. Thank you. Another question I've always tried to explain is it true that women tend to develop more soft plaque than men? And is that kind of associated with the whole microvascular disease versus the traditional large vessel?
Yeah, so women in general, in terms of their plaque formation, yes, they can be more susceptible to soft plaque. And when we mean soft plaque, we mean plaque made predominantly of fat as opposed to calcium. In general, we are more concerned or afraid of soft plaque because something that's reinforced with a rock or calcium tends to not break off. And it's actually that subtle break off or blockage of the blood vessel that causes an infarction or heart attack. So the soft plaque we do get concerned about. But once again, what we've noticed is that the areas of issues is the smaller blood vessels. So it's not that the smaller blood vessels itself have the soft plaque. They may, but it's also that the smaller blood vessels, for whatever reason, are too small for the region that they are supposed to supply in the muscle.
Okay, thank you for explaining that.
Now, many women, younger women, tend to just see their gynecologist as their primary care doctor, and that's all they see. Is there something, and typically they're not doing any cardiovascular prevention for the most part, for someone who's has a higher risk, say a family history, who's in their 20s and 30s, is there something that you would recommend that they do above and beyond what probably the routine gynecology workup involves?
Absolutely. So I think the issue is timing. We should be seeing women in the prenatal, preconception period, not when the ship has sailed and they're in their third trimester. So if you yourself have a family history, and remember our women-specific risk factors, if you have chronic inflammation, if you have Crohn's disease, ulcerative colitis, right? If you have a history of obesity or prior history of preterm delivery, right? You should be talking with a cardiologist as well prior to you wanting to conceive. If this is another pregnancy, right, and you have that prior history, it's the same thing prior to conception.
Okay. And I mean, I've heard that sometimes pregnancy is coined the term cardiac stress test as well, because of all the changes and stress that the body goes through. Would you agree with that or no?
I think women are amazing, and I completely agree with that statement. So, all the changes that happen in a woman's body is miraculous. You increase your total amount of volume or liquid in your body. Your heart rate goes up. Your SVR, which means your overall resistance, goes down. All of these changes are made so that you can optimize your placental growth and your little baby's growth. Because of all those changes, your heart has to work much harder to keep up with all the circulating blood volume and all the other hormonal feedback that's occurring. So yes, it is pregnancy's stress test.
Would you say pregnancy alone is a risk factor for heart disease later on in life or no? Or is it more so the preeclampsia and the gestational hypertension, gestational diabetes? Like if you have a fairly normal pregnancy itself, is that putting you at increased risk of anything down the line?
No, pregnancy itself is not an independent risk factor. What is, however, are some of those other things we mentioned in terms of chronic inflammation. So if you have preterm delivery, if you have a multi-gestational delivery, meaning twins, if you have a history of chronic hypertension or high blood pressure prior to the pregnancy, and then the development of blood pressure throughout the pregnancy, so 20 weeks or later, if you're told you have that, you now have a twofold increased risk of coronary artery disease, heart failure, and stroke.
And women are now tending to have their babies later in life. Does that increase your risk, say someone over the age of 40?
Yeah, so in general, advanced maternal age is thought to be another women-specific cardiovascular risk factor.
Interesting.
Yes.
Man, you've just answered so many questions now.
I do
This
have
is great. Yes.
something else I want to
would love
add
more.
about that. So heart disease affects women at every stage of their life, right? Prenatal, perimenopausal, postmenopausal, right? So I think it's important that we really take note of a woman's pregnancy and obstetric history because that is overlooked. If you have someone who is coming in postpartum, for example, let's say, you just delivered, perhaps that may be too early in the discussion in terms of preventative cardiovascular care, right? But if you do have that history, you may want to start thinking about having those discussions about preventative care right around the age of 40 to 45. I say that because menopause, as we know, is around age 51. We lose that protective effect. But you may be at a higher risk of cardiovascular disease prior to menopause if you have that pregnancy history. So that's why I say 10 years prior, around the age of 40, 45. Having that discussion, bringing it up, advocating for yourself and saying, hey, you know what? I've had a preterm delivery. I've had preeclampsia, right? Should I get screened? That is really important to have that discussion going, and having those other markers like we checked is a great idea. Having a calcium score, having overall another risk reassessment to know, should I be on medications like an aspirin or statin prior or sooner than what was once thought?
I love how you put the age to that in a sense, because I often get asked, well, what's too early, right? So like if somebody's in their 20s, they hear of their parent, or 20s or 30s even, they'll hear of like their parents going for a calcium score and they're like, should I do one now? And oftentimes I'll wait. And I have to say I'm a little guilty for not asking too much about the preeclampsia or the gestational diabetes or hypertension as well. And so it sounds like it's 40 to 45 is a good start at that screening. Like, do you ever do it a little earlier?
Yeah, so we have to think about the test. So calcium score was designed for patients between the age groups of 40 to 70. We're looking for coronary artery disease, right? Now, earlier in the 20 to 40 group, typically what women typically have, if they have that history, is progressing to chronic hypertension or high blood pressure, right? So yes, there is a role for screening earlier than that, but not so much in the calcium score, right? It's going to be simple checks like home blood pressure monitoring, right? Also thinking about the other risk enhancers, having a lipid panel, an A1C, doing that at least once a year would be very important. But also this impacts our day-to-day life, because let's say you're on hormonal contraceptive, right? Is the birth control you're on the appropriate one for you if you have chronic hypertension? As we know, estrogen can increase your blood pressure. So maybe a combined oral contraceptive is not the right one. Maybe it should be a non-hormonal method of delivery, an IUD. So that's a little bit different for everyone, but really easy checks like checking your blood pressure is a great start.
In your opinion, do you think that the widespread use of GLP-1 medications is doing anything to lower cardiovascular risk?
I love that you asked this. I'm a big advocate for the GLP-1s. And to answer your question quickly, yes. We've noticed a lot of unintentional cardiovascular benefits with these medications. Overall, we know that weight is also a chronic inflammatory component. And so with the loss in weight, people's sleep apnea have been corrected or cured. People's high blood pressure, hypertension has been improved. Their glucose profile has been more favorable. So yes, I think it is an important adjunct. And to date, I do not see any cardiac or heart major contraindications to one of these medications. If you're thinking about getting on it, absolutely do it.
And you mentioned sleep apnea. I also feel that women are way underdiagnosed with sleep apnea.
Yes. Yeah, I mean, just because you might be skinny and your neck circumference isn't large doesn't mean that your jaw doesn't fall backwards when you sleep, or, there's other things. So that's something that, when we screen for that in our office as well. And I have had conversations, and it's unfortunate when people in general, not just women, they're like, well, I refuse to wear a CPAP. And I'm like, so you refuse to do anything about it when this could cure your blood pressure, this could make you feel better and give you more energy, et cetera. So at some point you're going to feel bad enough that you will want to do it. So why not just do it now?
Right. I want to bring a couple of good points to what you mentioned. The first is, don't ever read what is the saying? Don't judge a book by its cover, right? So sleep apnea comes in many different phenotypes, right? It can be someone who's very skinny. It can be, a young woman, right? But the other thing is that sleep apnea can, if left untreated, create sudden cardiac death where you die in your sleep, cause a stroke, cause heart failure, cause irregular heart beating like atrial fibrillation. These are horrible things that can be prevented. And if a mask perhaps is just something that you've exhausted and you cannot accommodate to, there are other ways to treat it. We now have very much great advancements in that, where we have a stimulator that's implanted under the skin to help treat sleep apnea in certain candidates. So I don't want people to think that a mask is the only way. You may be a candidate for something that, doesn't look like a mask.
That's true. And I just want to know, in your practice, how do you integrate like lifestyle modifications or nutrition, stress management versus maybe traditional cardiology?
So I think it's all about the method of delivery and the type of learner that you may be. Some are visual, some are auditory. So I give a lot of different kind of components depending on the individual. If you're a podcaster like myself, there's a great podcast that I subscribe to called Zoe. But basically, it's a podcast that talks about a lot of nutritional lifestyle changes. The most recent hot topic was a protein shake, for example, yes or no, right? But other handhelds that I think are good to day is an app if you're an app person. I personally use Yuka, which is an app that uses a barcode and you scan it and it will humble you. Let me tell you.
We are big fans of Yuka.
Yes.
We tell everybody about it.
I verb it. I say Yuka it, right?
Yes.
And then other ways, if you're more of a kind of reading person, the American Heart Association has a great handout called the Simple 7. The DASH diet is also easily recommended. I'm a big advocate of that. But in general, the takeaway is if your great grandmother doesn't recognize what you put in your cart, it's probably ultra processed. If it has more than 5 ingredients, probably ultra processed, right? So what you want to do is take a pause, look in your cart. You want to make sure the majority of cart is deep green, leafy green, plant-based, and you want to make sure that you don't have too many boxes or packages items in your cart.
Exactly. I mean, we've had several nutritional podcasts that we're big advocates of everything you said. And another tip I always say is walk on the outside of the grocery store. If you're going down the aisles, it's probably not good for you. It's packaged.
Do you incorporate any biometric testing in your practice, like Oura Ring, HRV. Do you track that with any of your patients?
Yeah, so I'm actually a big fan of artificial intelligence incorporation because I think that's what most people have these days. So if someone has a smartwatch, an Oura Ring, I definitely say, give me your phone if you feel comfortable, and I have your consent, of course, so that I can take a look. I specifically am looking at measurements like your visceral adiposity because that's a chronic inflammatory component. I'm also looking at what your overall step count is. I'm also looking at your metabolic function or your MET, which basically tells me what your overall fitness level is. And then depending on, if it's an Oura Ring, is there any desaturations in the oxygen levels at night that may indicate that you have a sleep disorder?
Excellent. Love that.
I do too. Yes. Oh, wow. This is great. I mean, you go hand in hand with everything we do in our practice too. And so I love having you on, and you've just explained things so well.
If you don't mind, I wanted to make one more
Yeah.
addition to what your question was. So some other things that people can do, because I really believe in being preventative, not reactive in medicine, is they can do, a lot of times people ask, well, what's my goal weight, right? And I hate that question. A weight on the scale does not reflect what your overall health level is. So if you can get a smart scale, that's great. But something easy and very affordable is a DEXA scan. You can easily do that. It takes a couple minutes. It's, in and out. And I like to tell people, listen, schedule a DEXA scan 6 months apart. A baseline, right? So we can all be humbled, which will tell you how much visceral fat, how much muscle mass you have, and even if there's asymmetry, so that way you can help prevent injuries moving forward. And then 6 months later is an accountability to see, have we decreased our subcutaneous fat by, let's say, 5% or not. That's much more informative than a number on the scale.
Absolutely.
Absolutely. We do in-body in our office, and you can do that. DEXAs have just a slight more radiation than the in-body, so we could do in-bodies much more often. We do them like monthly since it's just electrons going through, but I love monitoring that. I mean, even just this morning, I had somebody who is not seeing the changes. The scale only went down 2 pounds. They gained like 4 pounds or more of muscle and lost 5% body fat. So it's just, I love seeing results like that. And
Give me their treatment plan.
right. It's peptides. So, but yes, I love it. And this has been so informative.
It really has.
I mean, thank you so much for coming on. And you have something you'd like to say about fundraiser you have going on, right?
I do. So as we know, February is Go Red Month. So we are trying to bring more attention to women's cardiovascular disease. The American Heart Association has an annual walk. We have one that's coming up in Broward County in the month. So if you would like to donate to participate or give even research funding, right, please donate. I am a part of the coronary crew. That is our name. So I will be walking on the behalf of further research for women's cardiovascular disease, and I'm sure you can get that information in the show notes.
Perfect. And participants can come walk as well?
I would love them to come join my team.
And do you know what day it is?
Yes, I do. You can find that information in the show notes.
Perfect. I'll put that on there. And also, will you please tell our audience how they can find you?
Yes, so I am accepting new patients. I am at Holy Cross Main Campus. We are located at 4725 North Federal Highway, Suite 501. I also see patients north at Lighthouse Point every Wednesday, and that's located at 2850 North Federal Highway, second floor. If you want to call the office, would love to hear from you. Our number is 954-772-2136. And I also have social media that is with my professional Instagram account. If you want to hear more about keeping your heart healthy, we can include that in the show note information.
Absolutely.
Do you see men too, or are you just solely women?
I'm non-discriminatory. I see men as well.
Great.
Wonderful. Thank you so much for coming on, Dr. Abelhad.
Thank you for having me. It's been such a pleasure.
Yeah, thank you.
Thank you.